Right, ladies and gentlemen, I'm going to tell you about the lockdown and our experience with lockdown, which is a device that I designed with a company called Surgicraft way back in 1995. I put in 10 between 95 and 2000. And since then, the product has taken off. And you want to know why you should use lockdown. And this evening, I'm going to give you a brief talk. And then Peter Hughes, who I do not pay, who I have nothing to do with apart from the fact he's an Englishman in England and I'm a Scotsman in England, and until recently he was totally independent from me.
Welshman.
Oh, a Welshman in England. Now, the operation that we devised was an operation which is shown in animation here. Incision through skin. Remove the lateral end of the clavicle. I normally take out 3 millimeters. And this is done particularly for grade 5 acromioclavicular dislocations. We have an instrument that goes round the coracoid. Remember, here you have the brachial plexus. When you put that round, you have to put it round very carefully with the tip on bone. This is called a length gauge or leader that goes round the coracoid and is used for measuring the length of the ligament that you're going to put in. And it has a magic coding system, which is completely stupid, because the 2 black lines there mean 11 centimeters. You pull down and reduce the clavicle. That 11 centimeters allows you to know the length. You work back from the 11. In this case, it was an 11 centimeter measurement. And now we are going to choose an 11 centimeter ligament. We are going to daisy chain the ligament onto the length gauge. We're going to pull the ligament under the coracoid. Now, this operation only takes 3 minutes on the animation. But actually, once you do it regularly, it only takes about 30 to 40 minutes. We then pass the length gauge behind the clavicle, and I usually use a cholecystectomy forceps to do that. Then, using the length gauge to pull down, and Peter is going to show you a clever way of doing this a little better, we then mark where we're going to put the screw in. And I think the screw should probably be a little bit more medial than that. It is important to drill this hole obliquely. You do not want to put the screw through the ligament. So make sure that the screw is being directed away from where the ligament will be. The hole is tapped to connect the ligament to the bone. We use a 3.5 screw. So we now pull the clavicle down, put the screw in. I direct the screw away from the ligament so that the tip of the screw, which usually sticks out a little bit from the bone, is actually back here and well away from the ligament. The reason why I've excised the lateral end of the clavicle is I've been doing this for chronic cases, and I believe it is very difficult to fully reduce the clavicle so that you get back to having your joint totally anatomical. When we first did this, our rehabilitation was very slow because I was worried about whether it was strong. I can now tell you, after using this device now for 17 years, it is very strong indeed. So we use a broad arm sling for 2 weeks only. We then mobilize without heavy lifting. Patients get back to work and driving at 2 weeks. Return to work at 2 weeks. If it's clerical work, return to driving at 2 weeks. Return to normal sports at 2 months or 8 weeks, and return to professional rugby at 3 months. And we have a lot of professional rugby players. The treatment of AC joint injuries remains controversial. In 1989, I published a paper that clearly showed in a prospective randomized trial that grade 3 dislocations should not all be operated on. Grade 5 should. Grade 3, you can treat conservatively without operation. And I still believe that. The treatment options are more than 60 different operations. And up till now, the best surgical option was not known. So in my unit, the majority of AC joint dislocations are still treated with no operation. However, if there is severe displacement, if there is a Rockwood grade 5, we operate. If the injured person is a very active professional and competitive sports participant with a grade 3 or a grade 5, we operate acutely. Most, however, are treated non-surgically, and we assess at 6 months and offer them surgery only if they have ongoing problems at 6 months. Most are offered reconstruction if they have symptomatic AC joint instability at 6 months. That means at 6 months they have pain and they have a bump. We have compared the lockdown with a group that have had a modified Weaver done, and no study to date has compared the two. And this study looks at a comparison of lockdown and the Weaver done. And this is a brief summary because we want dinner tonight. We don't want a boring lecture. 55 non-randomized patients treated for chronic AC joint dislocation and reviewed retrospectively. Some were treated using a Weaver-Dunn procedure with a Vicryl coracoclavicular sling, and some were treated with lockdown. All patients were assessed using an Oxford shoulder score preoperatively and a minimum of 12 months postoperatively. And we've also used a Nottingham clavicle score, which was described by Ed. Ed, would you like to stand up? And who's one of our medical students who's actually carried out a good validation of the Nottingham clavicle score, presented his work today. So we've seen the surgical technique. We remove the outer end of the collarbone for chronic, but I don't for acute. If you're doing an acute, you don't need to take out the outer end of the clavicle. Placing the ligament around the coracoid, pulling the clavicle down, and this is really important. You have to pull it down very hard. You must overcorrect. You cannot do this too tightly. You want the clavicle to sit slightly below the acromion if possible. And this is the final fixation here. This is our method of doing the Weaver done, we identify the coracoacromial ligament, divide the coracoacromial ligament from the acromion, remove the outer 3 millimeters, 5 millimeters of clavicle, make a little hole, and bury the ligament in the lateral end of the clavicle with a strong number 2 or number 5 ethibond suture. This is a vicryl braided loop. When I was at school, I was taught how to braid hair. In the middle of my operation, we have to stop. I get some vicryl suture, vicryl number 1, doubled, and I make a braid in the operating theatre. Why do I do that? I used to use vicryl tape. It costs too much money. So I make a bit of vicryl tape using number 1 vicryl suture, and we go round the clavicle and round the coracoid, and this reinforces the Weaver done. Why? Because the Weaver done fails. If you do not protect that repair during the first 6 to 12 weeks, your Weaver done will fail. So we had 31 patients treated using the modified Weaver done and 24 patients using the lockdown. And these are comparable groups. The reason we got the groups is that the lockdown were my patients and the Weaver done were carried out by the other shoulder consultants in Nottingham. And we looked at a mean of 21 and 24 months post-injury. The mode of injury, the presentation of symptoms, the grade of injury, and the time to surgery was similar. So they are comparable groups, but they were not randomized. So what did we find? For the Weaver done, we had more grade 3s. And for the lockdown, we had more grade 5s. So we were treating more severe injuries with the lockdown. These are the results pre-op in blue, and you can see that the Oxford score, that is a score out of 48, between the Weaver done group and the lockdown group are similar. 28 for Weaver done, 26 pre-op for lockdown. Post-operatively, the Weaver done group scored 42 out of 48 on average, using the Oxford score. The lockdown, 45 out of 48. That is not statistically significant. However, when we use the Nottingham clavicle score, we got 81 out of 100 for Weaver done and 93 out of 100 for lockdown. That is statistically significantly different. So in this, we've shown that the lockdown is better than the Weaver done, and we were doing more difficult cases. But this was where there was a difference. If you looked at the Weaver done and returned to work, this was before we knew that lockdown was really strong. The patients got back to work at 14 weeks after Weaver done, at 6 weeks after a lockdown. And for return to sports, they returned to sports at 25 weeks, 6 months after a Weaver done, 12 weeks after lockdown. Part of that is a surgeon's advice. So that is actually a little deceptive and perhaps a little bit unfair on the Weaver done patients, but we had seen quite a few failures in the Weaver done, so we were cautious and we didn't want to have failures. So we had a significant improvement comparing pre and post-op Oxford scores in both groups. The Weaver done pre-op Oxford score was 28, post-op was 42. The lockdown pre was 26 and post was 45. And the lockdown group returned to work earlier, and that was at 6 weeks, compared with the Weaver done 14 weeks. Every operation has failures. In this series, we had 3 Weaver done failures and 1 lockdown failure. And all of them were revised using lockdown a second time for that case, and for these 3 Weaver done failures, we used lockdown. We had superficial infections requiring antibiotics in 3 patients. 3 patients were unhappy. 1, Weaver done, had a complex regional pain syndrome. 2, developed neck and other problems with ongoing pain. 1 was Weaver done, 1 was lockdown. Now this is a retrospective study. I could be biased because I'm the originator. But we have today with us Peter Hughes, who has nothing to do with me, who is going to talk to you about his experience. We've confirmed that AC joint dislocation can be successfully treated using either procedure. But lockdown had a lower incidence of failure and allowed an earlier return to work. Now, I do receive royalties for lockdown because I invented it with Surgicraft in 1995. I just want to briefly mention, and I think Peter is also going to mention, one of the arguments that there has been about lockdown. It was previously called Surgilig, and that is that there is a concern that the lockdown may displace the clavicle too far forwards in relation to the acromion. We know from our studies, and you'll see the results in a minute, that we can pull the clavicle down and keep it there. The most common mistake a new user makes is that he does not pull it down tight enough. And I can guarantee you, if you're a new... How many people have used lockdown or Surgilig? Can you put your hands up? So we only have one user. Okay. You will make a mistake with your first 1 or 2 cases. You will not do them tight enough. It's very important to make it tight. So we looked at 18 patients who had AC joint instability using lockdown, and we looked at a comparison with 18 normal shoulders. And we were looking at the position of the clavicle and acromion across 3 hospitals. And we got 1 resident, a junior resident, to go and measure all the X-rays. And he was not biased. And he looked at the displacement of the clavicle in relation to the acromion on both the AP view and the axial or axillary view. And what he was looking at on the AP view was the measurement between the undersurface of the acromion and the undersurface of the clavicle, pre and post-op. And he was looking at the displacement of the front of the acromion with the front of the clavicle, pre and post-op. And these were the measurements he made. And these are the results. If we look at the controls, vertical displacement, 2.9. The immediate post-op treated with lockdown was 3.3 vertical displacement, and they stretched up to 5.2. These include some cases I did which weren't tight enough. So I can do better. If we look at the axillary view and looking at the anteroposterior displacement, preoperatively, 15.9, the controls were 4. Immediately post-operatively, we overcorrected and the clavicle was too far forwards because of the way the operation is done. But by 6 months post-op, That 4.2 is the same as the control group. So we don't have an excessive anterior displacement. Now, this is a poster at this meeting, which you're welcome to look at the poster stand, but it does show that you do not get excessive anterior displacement of the lateral end of the clavicle. So we are delighted with the result from the lockdown. I'm delighted that I can actually get my patients back to work more quickly. I've had patients flying from America. A physician flew in from America to have it done 4 years ago, a cardiologist, and that allowed him to get back to work very quickly. And my patients are pretty happy. My results are not perfect. We do have failures. I've had a rupture of a lockdown in a patient who fell downstairs. My colleague has a rupture of a lockdown in a prisoner in prison who had a bear hug from one of his friends. He grabbed him, squeezed him, and stretched the ligament. So if you apply enormous force, you can stretch the ligament, but if you repair the superior acromioclavicular ligament, that produces a biological healing which is satisfactory.